Hello everyone, today I am going to teach you about gout. Gout is defined as an inflammatory crystal arthropathy that is caused by the precipitation and deposition of uric acid crystals in synovial fluids and tissues. Gout is the most common inflammatory arthritis in men and in older women. The prevalence of gout is approximately 1%, with a greater than 5:1 male preponderance. Chronic hyperuricemia will lead to intra-articular uric crystal precipitation and deposition of monosodium urate monohydrate in the synovium. This will cause the release of inflammatory mediators and enzymes leading to aggregation of uric crystals and giant cells that will cause local joint inflammation, arthritis and deformities. The causes of gout and hyperuricemia includes decreased uric acid excretion through kidneys, increased uric acid production and increased intake through foods. The causes of decreased uric acid excretion through kidneys include renal failure, lactic acidosis, alcohol consumption and drugs like thiazide and LEAP diuretics, low-dose aspirin, cyclosporine and pyrazinamide. The causes of increased uric acid production includes myeloproliferative and lymphoproliferative disease, psoriasis, high fructose intake, glycogen storage disease, inherited disorders, Lesch-Nyhan syndrome. Taking red meat and seafood can also increase uric acid levels. All patients with gout have hyperuricemia at some point in their disease. However, most hyperuricemic individuals never experience a clinical event resulting from uric crystal deposition. The clinical manifestations of gout may include recurrent flares of inflammatory arthritis, gout flare, a chronic arthropathy, accumulation of uric crystals in the form of tophaceous deposits, uric acid nephrolithiasis, a chronic nephropathy. The three classic clinical stages in the natural history of progressive uric crystal deposition disease, gout, are gout flares, intercritical gout, chronic gouty arthritis and tophaceous gout. The classical presentation of acute gouty arthritis is as follows. It is usually acute monoarthritis, which affects the first metatarsophalangeal joint in over 50% of cases known as podagra. It includes acute severe pain with overlying erythema, decreased range of motion, swelling and warmth. It is self-limiting over 5-14 days, with complete resolution. Symptoms are likely to occur at night, typically waking the patient. Other joints involved are knee, finger, ankle and wrist. Upon resolution of a gout flare, the patient is said to have entered an intercritical, between flares, period. Intercritical periods early in the course of gout are most often entirely asymptomatic. Intervals between gout flares are of variable duration. Chronic gouty arthritis is characterized by collections of solid urate, accompanied by chronic inflammatory and often destructive changes in the surrounding connective tissue. Tophi are often visible or palpable and can be present on the ears or in the soft tissues, including articular structures, tendons, or bursa. Tophi are typically not painful or tender. They may attenuate the skin, revealing a yellow or white color. On the ear, they do not transuminate. Tophi have a white color, differentiating them from rheumatoid nodules. Tophi can ulcerate, discharging white gritty material, become infected or induce a local inflammatory response. The differential diagnosis of gout include septic arthritis, infective cellulitis, reactive arthritis. The blood test will show neutrophilic leukocytosis and raised levels of ESR and CRP. X-rays, ultrasound, and MRI also help diagnosing the gout. The X-ray findings include bony erosions that are typically punched out with sclerotic margins and overhanging edges, sometimes termed rat bite erosions. This X-ray shows characteristic erosions with overhanging edges seen in gout. The joint aspiration will show the presence of long needle-shaped crystals that are negatively birefringent. The synovial fluid cell count will show the white blood cell count greater than 2000 per microliter with greater than 50% neutrophils. The management of gout will include lifestyle modifications, like limiting alcohol consumption and limiting the intake of purines and weight loss if patient is overweight. The treatment acute gout flare includes number 1, non-steroidal anti-inflammatory drugs, like indomethacin and ibuprofen. They are contraindicated in renal impairment and should be avoided in elderly patients taking warfarin due to risk of gastrointestinal hemorrhage. Number 2, colchicine. It is the treatment of choice. It works by inhibiting microtubule assembly in neutrophils. The most common adverse effects are nausea, vomiting, and diarrhea. It can be used in mild to moderate chronic kidney disease but not severe. Number 3, glucocorticoids, like prednisolone, methylprednisolone, or intra-articular administration. Glucocorticoids are preferable if there are contraindications, intolerance, or inadequate response to non-steroidal anti-inflammatory drugs or colchicine. Number 4, canakinumab is effective, but extremely expensive and so seldom given. Number 5, local ice packs can also be used for symptomatic relief. Treatment of chronic gout includes urate-lowering therapy. The first line includes xanthine oxidase inhibitors like allopurinol and febuxostat. The second line includes uricosurics like probenecid, and the third line includes recombinant uricase like pegloticase. The indications at urate-lowering therapy includes damage due to chronic gout seen on imaging, tophi development, and frequent gout attacks, greater or equal to 2 per year.